Hi, and welcome to Chapter 4, Positioning of the Elbow. We will be concentrating on 4 main positions for the elbow: your AP, your lateral oblique, and your medial oblique. These are also referred to as your internal rotation and lateral rotation. When we are x-raying our elbow, we want to fully extend the elbow out. Make sure that it's on a nice level plane. You can do this by raising the table or by placing a sponge underneath the hand if they are not in a level plane only. Your central ray for all of these will be your mid-elbow joint. You need to open up enough collimation so you have a good 2 to 3 inches of the distal radius and ulna and humerus. If your patient cannot flex their elbow, you can partially flex with a sponge, and you can rest that distal portion on the table and then have them stand up so they're resting that distal radius and ulna on the table. This is only to be done if your patient cannot open up their elbow joint all the way or fully extend, or if they are in a cast and they are immobilized so that they have a part angle to their arm. When we are looking at our elbow, there's some anatomy that I would like to point out. The anatomy is very similar to your forearm, but you have your radial shaft, your ulnar shaft. Remember, these are also referred to as the body. You have a humeral shaft or humeral body. You have your medial condyle, your lateral condyle, your radial tuberosity, your radial head, and the olecranon process of the ulna that should all be demonstrated on your film. Your lateral elbow also has your humeral shaft, your radial shaft, your ulnar shaft, your olecranon process, the head of the radius, your coronoid process of the ulna, and that medial supracondylar ridge. When we're positioning our elbow, we're going to concentrate on the 4 positions: AP, lateral or external oblique, or medial and internal oblique. So positioning for your AP elbow, you need a 10 by 12 image receptor. If you're doing digital radiography, you will want your 14 by 17, but collimate down. KVP is anywhere between 60 to 65 KVP, 2.5 mass. So for our purposes, we're going to do about 60 KVP, 5 mass, just like we did with the forearm. You will fully extend your elbow. Your hand is supinated. You want a true AP to make sure that those epicondyles are parallel to your image receptor. Central ray is to your mid-elbow joint, and your SID is 40 inches. You may use a half lead for shielding. When we are evaluating our elbow, your distal humerus is in profile. The epicondyles are going to be parallel to your image receptor. That radial head is slightly superimposed. You have evidence of collimation and optimal density and contrast. Your medial rotation means that you are going to go from a supinated position to where you rotate your hand over so that it's pronated onto the table. Your central ray is still directed to that mid elbow joint. Medial oblique, you're going to do a 45-degree rotation, so basically your patient is leaning at their shoulder and rolling out, and again you're going to center right to that mid elbow joint. When we are taking a look at the lateral oblique, you will see the radial tuberosity is now no longer superimposed over your ulna. You can see that radial head and neck in profile. Your lateral epicondyle and capitulum are also in profile. Your medial oblique, your coronoid process is now in profile. Your trachea and medial epicondyle are in profile. Your lateral elbow, just like in the forearm, you want to flex them 90 degrees so that your humerus and forearm are now parallel to your image receptor. Your epicondyles are now perpendicular to your image receptor. 3 concentrated arches should be visible. The olecranon process is in profile, and you should have optimal exposure technique. Special projections include the acute flexion, trauma axiolateral, which is called the coil method, and the radial head projections. Every once in a while, you'll have especially orthopedic doctors ask for these. You're going to acute flex your elbow. Your central ray is directed to the humerus, so the distal portion of that humerus. and forearm. You're looking here at the olecranon process, your medial epicondyle, that neck of the radius, and part of the ulna. Your trauma axiolateral medial projections or coil method, central way is 45 degrees towards the shoulder, you're 90 degrees flexed, and what you're going to do, it's called round the clock views, where you rotate the thumb. Sometimes we have trauma patients. With the trauma patients, you do want to keep them laying on their back, especially if they're on a stretcher board. We can place a sponge or something else that's available in the room underneath them to raise them up. You will then direct your central ray to the appropriate location depending on what you're trying to see. So trauma axiolaterals, do your best to try to superimpose and keep that radial head so that it's superimposed over that joint. If you're looking at the coronoid process, you can angle so that you throw that off, that radial head off. So we'll practice in lab doing a couple of these trauma situations. The radial head for the lateral medial projections, you'll see that you're turning the hand, but you're keeping that elbow flexed at a 90-degree angle. So these are all methods that you can use to throw that radial head off, depending on if they're looking for a fracture or not. Your cast conversions, remember that for a plaster cast you want to increase your KVP 5 to 7. Wet plaster cast you need to do 8 to 10 KVP increase. Most of the patients you're going to see come in are going to have fiberglass cast, and remember that it's about a 3 to 4 increase in KVP. Some trauma terminology, a lot of times we'll see patients with dislocations, sprains, contusions, which is a bruise. Your fractures will come in as well, and they'll be placed in a cast, and so probably one of the more challenging x-rays to get are going to be that elbow in a 90-degree angle with they'll have a little bit of a twist to their elbow and trying to get that into an AP in a lateral position.